Good afternoon. I am so appreciated with Dr. I invitation. It's for me a great honor to be here and to talk about this topic. All of you know very well that breast cancer is the most common cancer for women all over the world, and it's the first cause of death. And for us, it's so important to know what to do with these patients that are surviving breast cancer and came to our consult. I declare not conflict of interest. And in this situation, what are the potential scenarios we might face? Could be a young woman, premenopausal, with reproductive desires, and we need to take care about fertility preservation and about subsequent pregnancies, or that people that are without reproductive desires. In that case, we need to know what to do about contraception. Or in the most of the cases, the postmenopausal woman could take our attention, and we need to know the management of menopausal symptoms and if it is possible or not to use MHT. And we need to know too the gynecological side effects of selective estrogen receptor modulators, aromatase inhibitors, or chemotherapy. What related to fertility preservation? The role of healthcare providers, it say that all oncologic healthcare providers should be prepared to discuss infertility as a potential risk of therapy. This discussion should take place as soon as possible once a cancer diagnosis is made, and can occur simultaneously with the staging and the formulation of the treatment strategy. In this aspect, there are different conclusions and future perspectives. Sofia del Pozo Lerida said that oncological healthcare is nowadays far from being solely the cure of cancer, providing hope of future fertility following oncologic treatment significantly increase the quality of life of the patient and help them to cope emotionally with cancer. Different techniques exist, and the most appropriate should be chosen depending on the characteristics of the patient. Oocyte petrification is currently considered the first line of option. In conclusion, fertility preservation is nowadays possible and should be integrated as part of the oncological health care. What about the safety of pregnancy after breast cancer? There are larger registry studies that have not shown a higher risk of recurrence for women who get pregnant after breast cancer, and even some suggestion of improved survival. For this reason, the survivors currently on tamoxifen, who are trying to conceive, it is recommended to have a washout period. In this review and meta-analysis, we can see that the related to event-free survival, there are no difference in people that became pregnant with the control group, and in the overall survival, we can see that there is better the evolution of the patient that became pregnant related with the control group. Because of that, the conclusion are that the present systemic review and meta-analysis of retrospective cohort studies show that having a pregnancy in patients with prior history of hormone receptor positive early breast cancer appears safe without detrimental effect on prognosis. Following adequate treatment and follow-up, pregnancy should not be discouraged in this patient population. This is a very important study related to tamoxifen for the patient treated as a adjuvant treatment that are willing to become pregnant. This study is enroll a lot of patients that receive an adjuvant endocrine therapy during 18 to 13 months and wished to interrupt therapy to attempt pregnancy. The primary endpoint of the study was breast cancer-free interval. After 3 years of follow-up, we can see the results, the first results, where you can see there that breast cancer event, there are no difference, and in distant recurrence, there are less recurrence in the group that stopped the medication, became pregnant, and then restart the medication. Among select women with previous hormone receptor positive early breast cancer, temporary interruption of endocrine therapy to attempt pregnancy did not confer a greater short-term risk of breast cancer events, including distant recurrence. FIGO make a pregnancy after cancer advice in 2025, and we can see there that the incidence and mortality of breast cancer is the first worldwide. About the counseling guide, we can say that they say, consider the duration of tamoxifen treatment, and it is currently recommended to discontinue tamoxifen for 9 months before conception. Consider resuming treatment after delivery. The duration of trastuzumab treatment, pausing it during the period of periconception, given its potential of embryotoxicity, and resuming it after delivery. Cancer treatment for patients with breast cancer can be resumed immediately after delivery and 2 weeks after a cesarean section. In women with mutations, bilateral salpingo-oophorectomy during cesarean section should be considered. Women who undergo breast surgery or radiation therapy experience reduced milk production. Because of that, breastfeeding is not recommended while the patient is receiving chemotherapy, but in that case that they are able to breastfeed, this option appears to be safe in terms of breast cancer recurrence. Finally, they say that interdisciplinary teamwork need to be they take care before pregnancy, during pregnancy, and postpartum. What happened with the contraceptions? The unrestricted contraceptive option for breast cancer are condom, diaphragm, copper IUD, surgical method. These both are the first line, but the guys say that the breast cancer patients, current breast cancer or past breast cancer, are contraindicated for all forms of hormonal contraceptives. What about the menopausal management? The vasomotor symptoms are often more severe in breast cancer patients due to side effects of endocrine therapies and abrupt onset of symptoms with chemotherapy-induced or surgery-induced menopause. There was used a lot of antidepressants, anticonvulsivant, alpha agonists, antimuscarine medicines. But nowadays, in the last time, neurokinin 3 receptor antagonists for menopausal flashes, specifically with fezolinetant, shown to reduce long-term 52 weeks hot flashes frequency and severity. Fezolinetant is a non-hormonal treatment for vasomotor-associated menopause. It's an oral neurokinin 3 receptor antagonist. And in the last year, started the specific study related to patients with breast cancer that are receiving adjuvant endocrine therapy. The highlight first. What says International Menopause Society white paper in 2024? MHT is conventionally contraindicated in women with hormone receptor positive breast cancer and endometrial cancer. However, depending on the degree of impact of quality of life and the efficacy and tolerability of the non-hormonal alternatives, some women may be willing to accept the risk of using or going back to using MHT. There were a lot of papers trying to demonstrate the possibility, but they were stopped. The most important habits, Stockholm Liberate, because they increased the number of recurrences. However, there were a lot of retrospective studies that demonstrate no influence in the recurrence. But if you try to make to know what is the current attitude of MHT in breast cancer survivors, patients have the intention to receive hormone therapy in the 58%, but only 5% of physicians were willing to prescribe. We can say that these studies highlight that whilst the burden of menopause is great, the fear of recurrence is greater, especially for the doctors. There is a paucity of data related to impact of MHT on oncological outcomes in breast cancer patients. Defining a risk of recurrence for breast cancer survivors using HT is imperative, and oncologic risks must be weighed against quality of life. Future studies evaluating low-risk patients with low-dose HT may be feasible. Randomization could be also unethical, because if the patient like to receive MHT, is not ethical, put this patient on the placebo group. At all, we can say that with this new development and safer MHT agents, is now the time to re-examine the role of MHT after breast cancer. Gompel said that in conclusion, there is no recommendation to use MHT in breast cancer, and non-hormonal alternatives should always be preferred. In rare cases, the quality of life is severely impacted and is the last line of treatment. Sorry. The assumption that in the case of triple-negative breast cancer, the assumption that triple-negative is completely hormone insensitive is incorrect. However, the direction of the effect of the alternative pathways is not always clear and will need to be investigated. The management of endocrine syndrome, genitourinary syndrome of menopause and sexual dysfunction is so common, especially in women that are using or taking aromatase inhibitors. The first-line recommendation for treatment include not hormonal local treatments. There are two medicines FDA approved, like DHEA, progesterone, or ofemifen. They are under investigation. The hyposexual desire disorder, we need to take into account. In some countries, there are these two medicines, flibanserin and bremelanotide. The side effects, tamoxifen in premenopausal woman, menstrual irregularities, ovarian cysts. In postmenopausal women, as like an agonist, and at the level of uterus, can be reported increase of endometrial hyperplasia and cancer. Aromatase inhibitors, the adverse effects are related to estrogen, general estrogen deprivation. Chemotherapy induced amenorrhea is so common, especially after the 40 years old patients. In summary, there are currently 4 million breast cancer survivors living in the USA and nearly 8 million around the world diagnosed only in the last 5 years, making it the most prevalent cancer in the world. It is crucial that women's health providers understand how to guide survivors in contraceptive counseling, safety of future pregnancy, menopause management, and sexual dysfunction. Providers should know the gynecologic side effects of endocrine therapy that are used in treating breast cancer. And these survivors, remember, come to us to our primary care provider for help in this improving their quality of life. Thank you so much.
Thank you, Professor Nestor Garello. It was a wonderful talk on breast cancer and breast disease, and it's one of the big killers in India as well and almost all over the world. And it's important for us to propagate the idea of prevention and, of course, other areas of breast cancer which are very important, and new upcoming areas are areas of fertility preservation, because a lot of younger women are having cancer, and many of them are having a good 5 years, nearly complete 5 years survival, and many of them get married, and so it's very good to know that more and more people who have early breast cancer are going in for fertility preservation, as both in the form of oocyte freezing and ovarian tissue freezing, both of which I've been doing for the last since 2007 in India. And we have to propagate mainly the prevention aspects. Clinical breast examination has to be propagated more and more aggressively, and early pickup of breast disease is very important to have effective management for these patients. So I'd like to thank you that you have come all the way online from Latin America, and wish you the best, and we look forward to meeting you in the FIGO conference in Cape Town. This also, the Congress here is endorsed by FIGO and is jointly being done by FOGSI, our Indian Federation, as well as the local city federation, the Mumbai Obstetric Gynecological Society.